All right, thank you very much. I'd like to thank the Fellowship Council, Dr. Scott, Dr. Feldman, for the opportunity to present. I have nothing to disclose. So the objectives of my presentation will cover the Fellowship Council mission statement, the gravitas associated with video assessment and surgical fellowships, what is known about video assessment outside of surgery, its applicability in surgery, some of the pitfalls and future directions. So I'll begin with the mission statement. The Fellowship Council is an association of program directors and specialty societies charged with oversight of fellowship training programs in order to uphold uniformly high standards and produce well-trained surgeons. So the way I translate this into my own words is that it's incumbent of all surgical faculty within the Fellowship Council to improve upon contemporary training paradigms to ensure trainee competence. Now, this has come to the forefront in recent years, and I'll go through that during my presentation, but this segues naturally into video assessment in surgery being of great relative importance right now. So where does the gravitas originate from? So the American Board of Surgery established in the academic year 2015-16 and going forward that all general surgery residents needed 6 operative performance assessments as part of their application to sit for the qualifying examination. Now, what's probably more important to the people in this room is that these performance assessments required an attestation from the program directors, citing that, yes, they've completed it, and this is very important. So shifting the onus away from necessarily the trainees, but on the program director, another board-certified surgeon, and somebody who has a lot of commitment to a large number and all of the surgical trainees in the country. So some of the questions that are surrounding video assessment that we probably all ask ourselves, depending on our levels of comfort and experience, focus on, well, how is it actually performed? Is there any data? If so, where is it? Probably the most important question to everybody in this room is, how is it linked to clinical practice and outcomes? And then finally, is it really ready for prime time? Fortunately, these will all be addressed by experts in the field in the presentations to follow mine. So I'd like to begin with a general discussion about where does video assessment exist outside of surgery? And believe it or not, it's currently the most common form of employee recruitment in businesses, both nationally and internationally. And so human resources departments for many major corporations throughout now prefer the video interview as their primary initial assessment. So many of you are familiar with the real-time methods such as Skype. Most of you probably in this room have used Skype at one time or another. The iOS platform FaceTime. And then a few companies well-established who provide very high-quality software and platforms for recorded platforms such as HireView and SparkHire. And this is actually the recorded initial video assessment is the preferred method for most companies. So what this is software that allows an internet-based platform. If a company is looking to hire, they put their job descriptions, they put a link to create an account to one of these companies that they've paid for their use of their software. The applicant then gets a job description and a scripted interview of typically 5 to 10 questions that they will have to answer the questions in a video format and submit it online. So you can imagine some of the sort of advantages of doing this, and I'll review them here on the next slide. So in terms of efficiency, well, it likely does cost less both for the company and the applicant. Less, not necessarily have to schedule interviews, fewer phone calls, fewer emails. If you have a very good applicant who lives in Washington, D.C., and they're looking at a job in Chicago, they don't necessarily have to travel to interview to pass through the first phase. And so you can see that there's some efficiency built into that. Furthermore, you're able to track employee performance. Companies will use the initial video assessment. If they've hired this applicant, they'll go back 1, 2, 3 years later and see how that applicant has done and look at the video. More importantly, they might compare multiple employees that they've hired. They have similar job descriptions. They'll look at the initial video assessment and go back and track performance. and try to predict why one employee was more successful than another. This is the basis of many outcome studies that many of us perform already. The companies feel that the interview and the assessment is more consistent. With a scripted first interview, there's less inter-rater variability in the assessment, and they feel it's more consistent and potentially more objective. Now, the interview itself is like anything else, where how well the interviewee or the applicant, in this case, how well they use the software. So some videos might be better than others, and we see this when going to any session in SAGES. And so you get the sense that if they're very good at editing their videos, they're probably very good at actually doing the procedures. For instance, if the candidate's fumbling around with a microphone or picks a poor backdrop to do the interview, maybe that shows a little bit of lack of experience and lack of maturity. And also, and finally, the companies feel there's an easy eject button. The video can be stopped at any time, or if it's a live feed, you just accidentally hit the red button if you don't like the candidate. So. All right, so how does this cross over and its true applicability in surgery? So I'm going to do sort of an itemized response to each of these purported advantages. So from efficiency, well, potentially your trainee develops competency faster with video assessments. This has been a hot topic, the American Board of Surgery, numerous presentations, the American Surgical in the past year or two, looking at autonomy and competency. Tracking employee performance, well, you compare maybe the first video and the last video of the same procedure over a month, 2 months, over a year. I currently do this in my current practice. I typically have a resident for about 2 months. We'll record the first laparoscopic cholecystectomy or hiatal hernia. I will then record probably one of the last ones, and I'll sit them down and make them watch both. And I just sit there, and I try actually not to say anything. And it's amazing to see these, over a 2-month process, the maturity that they have developed, that they can actually see their improvement on their own. You're able to compare employees' performance. You take videos from multiple trainees at the same PGY level, and certainly you start to develop in your own mind, and I think we've all done this, maybe not through having a log of all these cases, just from having worked with so many trainees over the years, but now you get maybe a slightly more objective assessment of top 10%, bottom 10%, et cetera. Now, you might do your faculty some favors, especially if video assessment becomes prime time and critical for every fellowship, is that if you have a more consistent interview and assessment, and it translates to here is, if you're going to video assess certain procedures in your training program and you develop a specific criteria, well, you've just taken the onus off of your faculty member. And we all understand the concepts of doves and hawks and assessment. This might take away some of the pain and some of the variation between faculty members doing the same assessments. Again, documented command of technology, how they use the camera, triangulation of instruments, surgical stapling, energy, robotic platforms. A lot of this can be seen very obviously on a video. And although there is no easy ejection button, especially once they've matched, but the reason there's no easy ejection button is that we actually don't have the right tools or enough objective assessments of trainees when they're not performing. And so this, with expectation for video assessment, it actually allows you to give something concrete to the one who's not performing and let them see it for themselves. And so it's not a personal or a bias, well, I don't like you, so you're not a very good surgeon. You might be able to eliminate some of those problems by having a repertoire of video assessments for specific candidates, especially for those who are not performing. All right, so let's talk about pitfalls, and I'll give you a very personal story about this. My wife and I recently transitioned from nannies to au pairs, and the first assessment you get is a Skype interview with someone from another country. And I can tell you, after our first au pair, who flamed out in about 2 months of working with my wife and I, there were many things from that Skype interview that were just horrible that I didn't pick up on, and I wish we had. It would have saved us a lot of trouble. So for instance, poor choice of location. So the first Skype interview was on a city street, busy city, next to a bus stop, and every 5 minutes when the bus would come by, we'd lose connection for about 15 seconds. So you can imagine trying to have that conversation or doing a case where the camera goes out for every 15 seconds for every 5 minutes. that was probably a red flag. Maybe poor decision-making, poor preparation on the applicant's case. Bad internet connection kind of makes sense. Poor technical setup if they don't understand how to use it. If someone is sort of, excessively self-promoting their abilities, again, you miss up on some of the verbal cues if you're doing it through some of these methods. And finally, I think what's also important is that the applicant, in many cases, doesn't have the opportunity to go back and look at the video that they've submitted. So if they're interviewing for a job, once it's submitted, they can't go and pull it out and say, well, I want to do a redo. And they don't have access to it, so for the next time they go, even if they use the same software, they can't use the same video that they used previously. They have to do a whole new round. And so how does this cross over to surgery? Well, poor choice of location might be translated to maybe not being prepared physically, mentally, let's say for a case. Not reviewing the history and physical, diagnostic studies, just not being ready in the right environment to perform well. Bad internet connection. Well, if you're videotaping a case inside of an abdominal cavity, you have no perspective what's going on outside of the patient. You don't know the communication. How much is the faculty member assisting? How much are they actually doing the case? It's hard to tell. Only the two people who are present and doing the case would know. Poor technical setup. This is a problem I struggle with, is getting the circulator who's incapable of recording a case. I mean, I've gotten to the point where I put in all the information myself. I check the number of megapixels that I want, and I literally leave it on the screen to just hit the big red button, and it's unbelievable how many times we're incapable of getting it right, even after being prompted. Excess self-promotion, well, this leads more to the integrity of being a physician, but the trainee failing to recognize their limits. And this is kind of a big deal. And finally, not having the recordings. Well, the day before a trainee rotates with me, I specifically tell them to bring their own external hard drive, because we are going to record. I am going to make you save it. I even have a backup one in my bag, so when they fail to bring it, which is pretty common, I just give it to them my backup. So at any rate, the last point that I'll focus on is sort of future directions. Many may have heard of these things before, but just in brief, artificial intelligence or smart technology, we all sort of at some level use it, whether we know about it or not. Thank you, Facebook. So what artificial intelligence does is it, in a video assessment, focuses on the verbal and nonverbal cues. It's recording it. So if you're interviewing somebody, you try to focus on maybe their posture, the command of the language. You try to listen intently on what they're actually answering to the questions. But there's many things that you may miss. And so there might be software that's in the future that's be able to, if recorded, will be able to capture these things. And what it does is it provides some insight and engagement. It's the applicant who gets excited and leans forward when you talk about something they're very good at or passionate about. You do also get some sense of their knowledge. The other sort of novel thing is what's described as industrial organizational psychology. Companies are now employing psychologists who are specific scientific study of human behaviors in an organization or workplace. And what they're trying to do is interpret personality and witness behaviors on that initial interview assessment. Now, these psychologists are typically not present in a real interview, sort of in a live interview. But in those companies with the recorded interviews, they have them interpret the video as well, looking for things beyond just the content of the answers. And so again, how this crosses over, well, the verbal and nonverbal cues, when you're operating, you're not going to see those things. So maybe what we should be doing is recording not only in the body cavity, but also the room externally. And so you have side-by-side images of the case and what the trainee is doing. What it does is it provides insight in their engagement and knowledge and really the control of the operating theater. And I think this is, there are examples of, especially in previous open surgery videos, which show the whole room and sort of the atmosphere that goes on. But this is, I think, a critical part of being an attending surgeon. In terms of industrial organization psychologist, interpreting one's personality, well, in our institution, Indiana University, we actually have a PhD educator who specializes in intraoperative coaching and teaching, specifically focused at looking at the surgeon's, the faculty member's ability to teach the trainee. This person will come into the operative theater, will give you a summary. This actually gets submitted as part of your dossier for promotion and tenure. documenting your abilities to teach in what's considered a very unique training environment, like the operating theater. And then also witness behaviors. We have a sports psychologist as part of our education team who specializes in mental preparation. Planning ahead, going through the steps of the operation with practice. Then you do your performance, which is actually operating on a real patient. And then probably the most critical part is the post-operative debriefing, where this sports psychologist will talk to our trainee and say, well, how did it go? And I think it's that debriefing that's the critical step to see if the mental preparation actually helped. And we have multiple ongoing studies for this. So in conclusion, I think video assessments have arrived in surgery. And what I would recommend is that the time now is to start now to streamline these things into your surgical residencies and fellowship programs. Thank you.